Diagnosis. Okay, in advanced cases, it's not a big problem to find proper diagnosis. But in the initial stage of disease, or even in advanced case, we should confirm that this is real deficiency of hormones. Now, how to confirm deficiency of hormones? No, the best way is just to measure level of hormones. But again, you know that level of cortisol depends on many factors. For example, it's decreased at night, increased at day, so-called circadian rhythm. It depends on stress. And that's why the best way is to do so-called ACTH stimulation test. ACTH stimulation test to assess adrenal reserve capacity for steroid production. Now, the best screening test is the cortisol response 60 minutes after 250 milligrams of casinotropium. What is casinotropium? Casinotropium, this is ACTH. ACTH, but as remedy. We have remedy of ACTH, casinotropium. We give injection of this casinotropium intramuscularly or intravenously, and cortisol levels should exceed 499 nanomoles per liter, or 18 milligrams per deciliter. If the response is abnormal, then primary and secondary adrenal insufficiency can be distinguished by measuring aldosterone levels from the same blood samples. In secondary but not primary adrenal insufficiency, aldosterone increments will be normal. No, I told you already that we have cortisol, we have corticosteroids and mineralocorticoids. Aldosterone is mineralocorticoid, and ACTH stimulates only glucocorticoids, cortisol, and that's why in secondary adrenal dysfunction, cortisol level decrease, but aldosterone levels remain the same, because again it's stimulated by angiotensin II mostly. Now, this is how we should think about diagnosing. Okay, we have patients with weakness, hypertension, weight loss, hyperpigmentation. Again, do screening test, give casinotropium, and 60 minutes after check level of cortisol. If level of cortisol subnormal, possible adrenal insufficiency, primary or secondary, we can expect. Then plasma ACTH or plasma aldosterone increments 60 minutes after 250 milligrams of casinotropium we measure. And if subnormal aldosterone increment we detect, so if actually we have low level of cortisol and low level of aldosterone, well, this is primary insufficiency. If aldosterone levels normal, no, this is in this case secondary insufficiency. By the way, one more difference. If we have secondary insufficiency, if this happened due to low level of ACTH, of course, we'll never find one of the most important signs. Which sign absent? Hyperpigmentation, because hyperpigmentation happened due to high levels of ACTH. But in secondary adrenal dysfunction or hypofunction, ACTH level low. What about treatment? No, fortunately, now we know how to treat such patients. Fortunately, we know how to treat patients with aldosterone deficiency. All patients with adrenal insufficiency should receive specific hormone replacement. The same as for diabetic patients. Diabetic patients, they should use insulin. Patients with Graves' disease, we give them thyroxine. And in case of adrenal insufficiency, we also should give remedy which contain hormones, absent hormones. So again, like diabetics, patients require careful education about the disease, and replacement therapy should correct both glucocorticoid and mineralocorticoid deficiencies, because again, in most of cases, we deal with primary insufficiency, and in primary insufficiency, we have low production of both glucocorticoids and mineralocorticoids, and that's why we should give our patients glucocorticoids and mineralocorticoids. And actually, of course, patients should take these remedies forever. You know that I told you that in some cases, adrenal insufficiency may be results of our treatment. Why? Because in many disorders, in many serious disorders, we use high dosages of glucocorticoids. Glucocorticoids, this is most powerful anti-inflammatory, immunosuppressed, anti-allergic remedy. Glucocorticoids stop inflammatory process. And that's why in many autoimmune disorders, we use corticosteroids as a remedy. If you give such remedy just for a few days or even few weeks, nothing happens. Nothing happens. It's okay. But what happens if you give corticosteroids to your patient for a long time, months, years? What happens? In blood, patient will have high level of cortisol. Cortisol from tablets, not cortisol which produced by suprarrenals. If patient has high levels of cortisol, what happens with feedback mechanism? Production of ACTH, of course, decrease. Production of ACTH decrease, and the result, nothing stimulates suprarrenals or adrenals to produce cortisol. What for to produce if patient has it in his blood in high quantities? Okay, adrenals, they have a rest. It's good. But if this rest lasts for a long time, what finally happens? What happens with organs you don't use? If you don't use your muscles, you have atrophy of muscles. That's why it's so good to do in some sports. The same happens with suprarrenals. Our organism doesn't want to spend energy, nutrition to feed organ which is not useful, which is not used. And that's why if long time you give cortisol as a tablet, suprarrenals, unfortunately, start disappearing. Finally, what may happen? We have atrophy of suprarrenals, atrophy, substitution with fat tissues, for example. And what may happen? If you stop giving cortisol as a tablet, suprarrenals already can't start production of suprarrenals, of corticosteroids, mineralocorticoids. And unfortunately, patient will have serious problems. Patient will have adrenal insufficiency. And in such case, we may expect not chronic, but acute adrenal insufficiency. What is it, acute adrenocortical insufficiency? Acute adrenocortical insufficiency may result from several processes. On the one hand, adrenal crisis may be a rapid and overwhelming intensification of chronic adrenal insufficiency, usually precipitated by sepsis or surgical stress. First possible situation, patients suffer from chronic adrenal insufficiency. Sometimes patients even doesn't know about his problem. Okay, some weakness, some low blood pressure, some weight loss, nothing, no pain, nothing, and patient even doesn't know. And if in such condition, when patients suffer from chronic insufficiency, he experienced some stress. Stress meaning not some bad news, but real stress, like a surgical treatment, sepsis, severe inflammatory process, I don't know, COVID-19 infection, severe infection. What may happen? In case of stress, suprarenals should increase production of steroid hormones. They forced, please give us steroid hormones to fight with stress. But they're damaged. They can't. Okay, they try to do something. They release some amount of hormones. They try to work hard, and that's all. They can't work at all. They're so tight. No, just imagine if you have very weak horse. The horse doing something slowly, but now you should do something faster. You start beating your horse. Okay, horse start moving faster, but then drop down, die. The same may happen with suprarenals. If suprarenals weak, all stimulations may finally kill suprarenals. And that's why this is the case. When patients already have been suffering from chronic adrenocortical insufficiency and some stress, cause acute reduction in production of hormones and acute adrenocortical insufficiency. Now, alternatively, acute hemorrhagic destruction of both adrenal glands can occur in previously well subjects. Now, in children, this event is usually associated with septicemia with pseudomonas. This is one type of germs, or meningococcemia. This is so-called Waterhouse-Friderichsen syndrome. In children's, severe meningococcal infection may cause hemorrhage into suprarenals. As a result, acute insufficiency. In adults, anticoagulant therapy or coagulation disorder may result in bilateral adrenal hemorrhage, because in adults very often use anticoagulation remedies. Just again, COVID-19. At the beginning of epidemic, it was very popular to give anticoagulant therapy. Why? Because actually COVID-19 caused damage of vessels, may cause formation of actually blockage of vessels with actually thrombi process. And to prevent this, we give anticoagulant therapy. But it means what? That blood easily can go out from vessels. And if patient has weak vessels in suprarenals, this hemorrhage may happen in suprarenals. You know, someone has continuous nasal bleeding. The patient has weak vessels in his nose. But if patient has weak vessels in his suprarenals, give anticoagulant therapy, bleeding and damage and destruction of both suprarenals. This third and most frequent cause of acute insufficiency is the rapid withdrawal of steroids from patients with adrenal atrophy owing to chronic steroid administration. Now, this is what I tried to explain you. Patients suffer from bronchial asthma, severe bronchial asthma. And we need to prevent severe attacks of bronchial asthma. We give this patient cortisol. And as bronchial asthma chronic disease, we give this cortisol forever, all patients' life. As a result, we have atrophy of suprarenals. And if for some reason, you know, corticosteroids, good remedies, but with big amount of side effects. And patients decide, okay, I'm tired from side effects, I stop taking these pills, and I will tell my doctor about this. What may happen in this case? Of course, not immediately, but after a week, after withdrawal of steroids from patients, he may experience acute insufficiency, acute adrenal insufficiency. Acute adrenocortical insufficiency may also occur in patients with congenital adrenal hyperplasia or those with decreased adrenocortical reserve when they are given drugs capable of inhibiting steroid synthesis. Again, we are talking about drug side effects. Some remedies block normal synthesis of steroid hormones? No, that's why as a side effect, we may expect to see again acute adrenal insufficiency. This acute adrenal insufficiency, also known as adrenal crisis, long-term survival of patients with adrenocortical insufficiency depends largely on the prevention and treatment of adrenal crisis. So if you know that your patients suffer from chronic adrenocortical insufficiency, you should give these patients sufficient amount of substitutional therapy to prevent development of such crisis. For example, in case of infection, trauma, including surgery, gastrointestinal upsets, other stress conditions, all this necessitates an immediate increase in hormone. So if you know that you treat patient with chronic adrenal insufficiency and patient again experience stress, just increase dosage of corticosteroids. This may help to prevent adrenal crisis, In untreated patients, pre-existing symptoms are intensified. So now again, all symptoms of adrenal insufficiency becomes more advanced. So I told you about gastrointestinal problems like nausea, vomiting, abdominal pain. All this may be intractable. So again, pain may be so severe that surgeons decided that something wrong with abdomen. Let's cut and see. That's why before cutting, it's better to ask consultation of therapeutists, because therapeutists, I can't say much more clever than surgeons, but they have more knowledge about possible causes of such conditions. Of course, maybe you will be a surgeon and maybe you will remember about Addison disease, maybe not, because if you don't deal with such patients every day, you may forget about this. Fever, maybe, sometimes maybe fever, sometimes maybe not. Lethargy depends in somnolence and hypovolemic vascular collapse ensures. So lethargy means what? Patient may even be in lethargy, contract on your stimulation, don't reply. And remember that corticosteroids, by the way, why patients with Addison disease lose weight? This is mostly due to loss of water. Because what for we need aldosterone? What aldosterone do in kidneys? Aldosterone causes retention of sodium. Retention of sodium causes retention of water. As a result, we maintain our water electrolyte balance. Without aldosterone, sodium go out, water go out, patients lose water and may experience severe dehydration. By the way, aldosterone also increases blood pressure. So in case of absence of aldosterone, patient lose a lot of electrolytes, a lot of water, and the result, hypovolemic vascular collapse may happen. Hypovolemic, it means that no volume. Water go out, volume of blood decrease, and the result, even maybe a collapse, that drop of blood pressure. And don't forget again that corticosteroids also rise blood pressure. So it means that collapse may be due to lack of aldosterone and due to lack of cortisol. In contrast, patients previously maintained on chronic glucocorticoid therapy may not exhibit dehydration or hypotension until they're in a preterminal state, since mineralocorticoid secretion is usually preserved, and in all patients in crisis, a precipitating cause should be thought. So again, what we're talking about? If we have complete damage, destruction of suprarenals, we have absence of both glucocorticoids and mineralocorticoids, and absence of mineralocorticoids cause dehydration, collapse. But if it was withdrawal of cortisol in patients who are treated with cortisol, yes, due to atrophy, production of cortisol absent, yeah? But production of aldosterone remains more or less normal. That's why we don't have such advanced signs as severe drop of blood pressure, as collapse, as dehydration. In some cases, it's a challenge because it's much more difficult to find proper diagnosis. What about treatment? You know that crisis is emergency. In all cases, all crises, this is emergency. As a result, we start treatment immediately because without treatment, our patient may die even. No, treatment is directed primarily towards replacement of circulatory glucocorticoids and replacement of the sodium and water deficiencies. So, no, idea is very simple. If all this happens due to lack of hormones, just give these hormones to your patient. And of course, it shouldn't be tablets. In case of all crises, we use injections or even intravenous usage of remedies. We introduce corticosteroids, glucocorticoids, mineralocorticoids, intravenous to act faster. And if patient was dehydrated, lost water, lost sodium, of course we should give also water and sodium. So intravenous infusion of 5% glucose in normal saline solution should be started with a bolus intravenous infusion of 100 milligrams hydrocortisone, followed by a continuous infusion of hydrocortisone at a rate 10 milligrams per hour. So again, and don't forget that patient experienced nausea, vomiting. That's why patient needs some energy. That's why when you give glucose with normal saline solution, we substitute what? Glucose, energy, sodium, water, and of course we give hormones. First intravenously, at least 100 milligrams of hydrocortisone, and then continuous infusion because we create intravenous line, and patient get 10 milligrams of hydrocortisone per hour. And don't forget about mineralocorticoids. Don't forget about mineralocorticoids to replace absence of aldosterone too. Okay, that's all about this rather rare disease. Do you have any questions about Addison disease? Do you have any questions about Addison disease?
No, sir.
Okay, if no question, you know that this semester your next lecture will be 2 weeks later. One lecture in 2 weeks. That's why, see you next lecture. Bye.
Thank you, sir.
Bye-bye. Thank you, sir.